Hello everyone, my name is Dr. Fadi Safi. I'm an assistant professor of medicine at the Pulmonary Critical Care Department, University of Toledo Medical Center. I'm also program director for the Pulmonary Fellowship. I am happy to be here and I'm privileged to present today to everyone in the primary care department in our beloved Palestine, with a collaboration with the Canadian medical group. My presentation today will be about COPD and asthma for the primary care, which we call obstructive lung disease. So my objective of the lecture today will talk about pathology and diagnosis of chronic obstructive pulmonary disease, assessment and goal classification of the disease, management of chronic stable COPD, guidelines-based step treatment of mild, moderate, and severe asthma, and special types and phenotypes of asthma. I don't have any disclaimer, and I don't have any financial disclosures. So I start with COPD, and then later we'll talk about asthma. Start with COPD. Definition of COPD is a common, preventable, and treatable disease characterized by persistent respiratory symptoms and airflow limitation due to airway and or alveolar abnormalities usually caused by significant exposure to smoking or noxious particles. So you have somebody who smoked for a long time, and then later in life he developed that disease consistent of respiratory symptoms of dyspnea, chronic cough, etc., and airflow limitation. This is the prevalence of COPD. What's important here is that COPD causes 10% of global prevalence. It causes 3.2 million deaths a year, and is the third leading cause of death worldwide. And if you can see in the graph here, you can see that there is variation in the countries. For example, India and China represent 50% of COPD population worldwide, while the United States come at third, and then Brazil, and then the rest of the countries. So as you can see, it's a huge burden, it has a financial burden, and it has a lot of impact. And that's why we choose to talk about this disease. What are the risk factors for COPD? The most important risk factors, as we know, is tobacco smoking. It causes 80% of all COPD cases. Early life factors, mainly prematurity and low birth weight. And then exposure to secondhand smoke from the father or mother in the house. Socioeconomic status, outdoor pollution, occupational exposure, in which 20% of COPD is from occupation. So 80% is from smoking and 20% from occupational exposure. And these are mainly the occupation that cause COPD, mostly farming, from grain dust, mining, wood, and chemical, and also some genetic factors. So somebody whose parents or siblings have COPD is more prone to have COPD based on genetic factors. What's important in this graph, you can see that the lung function decline with age, and any person who at age 40 has a low lung volume, even though he has a similar exposure to smoke as somebody who has a large lung volume, his risk of COPD is higher. So not everyone develop the same lung volume as you age. The pathogenesis of COPD is very intriguing and very interesting. There's been a lot of data in the last few years about how COPD develop, and we now know and we understand the disease that start with cigarette smoking or irritants from occupation that will hurt or get treated with by the alveolar macrophages and by the epithelial cells. Both of them, they will secrete cytokines, including TNF-alpha, interleukin-1, or chemokines, gamma interferon, and tumor growth factor beta. All of those will affect the fibroblasts, lead to fibrosis, affect the T helper 1 and T helper 17 cells, leading to airway destruction, or the neutrophils, which releases proteases and lead to airway destruction and mucus hypersecretions. And if we talk about alpha-1 antitrypsin deficiency, this is where the enzyme affects the proteases. What's important here is that you need to understand is that the cell inflammation in COPD increase with the disease severity. As we move from stage 1 to stage 4 disease, we know that the percentage of cells involved is increased. Same thing in the CD8 or the cytotoxic T cells. You can see that the FEV1 decline as the FEV1 decline increase, the CD4, the CD8, the cytotoxic T cells in the airway increase. So talking about the alpha-1 antitrypsin deficiency, you need to suspect it in anyone who has an early age of onset, less than 45 years. Any patient who has COPD at age less than 45 years, even if you smoke heavy, you need to suspect alpha-1 antitrypsin deficiency. Or if a patient have asthma that's poorly controlled, also alpha-1 antitrypsin deficiency have been involved. Patients who have emphysema, not on the top part of the lung, which smoking caused emphysema on the top part, alpha-1 antitrypsin deficiency causes emphysema on the bottom part. Anyone who has chronic liver disease or cirrhosis associated with lung disease, necrotizing paniculitis, which is inflammation of the cell and the subcutaneous skin and subcutaneous tissue, ANCA-positive vasculitis, or first degree with emphysema or liver disease, you need to suspect alpha-1 antitrypsin deficiency. These are the different types of emphysema. As you can see on the CT scan, we call it centrilobular emphysema because it's at the center of the lobule. This is an pan-acinar emphysema, which is involve all the lung. This is a paraseptal emphysema. Most of the emphysema is around the septa. And this is a bullous emphysema where you can see huge bulli. So what do you do when you suspect COPD? How to diagnose and what's the assessment tools? You need to think about the symptoms of COPD, the risk factors, and then if you see any patient with both of these, you need to do a spirometry. So the symptoms are shortness of breath and chronic cough, and the risk factors, somebody who smoke or have a relative with COPD or work with wood or farming, etc., and he has chronic shortness of breath or cough, or he has exposed to pollution such as biomass fuel, then you need to do a spirometry. So these are the symptoms that alarm you to the presence of COPD in your patient. If you have somebody who has been short of breath for the last few months, has chronic cough with or without sputum production, has wheezing, chronic sputum production, recurrent infections, chronic bronchitis, you have recurrent attacks of bronchitis for 3 months in the last 2 years, and then history of risk factors such as smoking or exposure, childhood factors, as I talked before, and family history of COPD, then that will alarm you that I need to do a spirometry in this patient. And then after you do spirometry, then you classify the disease into 4 stages, gold stage 1, gold stage 2, gold stage 3, and gold stage 4. Gold is the global initiative for obstructive lung disease. So they classify the COPD into 4 stages. Gold 1 is mild. The FEV1 on the spirometry will be more than 80% of predicted. Gold 2 is moderate, between 50 and 80. Gold 3 is severe, between 30 and 50. And gold 4 is very severe. Usually patients have FEV1 less than 30% or they need oxygen therapy. And the important part about gold staging is that it correlates with mortality. The more severe the gold stage is, the higher the mortality is. So as you can see here, in 10 years, around 50% or 60% of patients who are severe may die from COPD. And that's what you need to tell the patients to encourage them to stop smoking. This is what we call the mMRC scale, which how you classify the patient's breathlessness. If the patient tell you that I get only short of breath with strenuous exercise, he's at mMRC scale 2 or 0. And if the patient have a shortness of breath with minimal activity or at rest, then he's at grade 4. And that's important to classify your patients. Anything in between goes grade 1, 2, and 3. This is the new ABCD assessment tool. And that's how the GOLD initiative now classify COPD. It's not only grade 1, 2, 3, and 4 based on the FEV1. There is other classification. We call it A, B, C, D. This is very important because you have a gold stage 1, 2, 3, 4, depends on the FEV1, and then you have A, B, C, D. And the A, B, C, D depend on 2 factors. One is the mMRC scale that we talked about before, and the other one is how many exacerbation you had in the last year. So somebody who has mMRC scale from 0 to 1, which means he's not very symptomatic, he's short of breath, is only with strenuous activity, and he doesn't have too lot of exacerbation, that gold stage A. On the contrary, if somebody is not symptomatic but have lot of exacerbation, that makes it gold stage C. And then you have B and D. B is somebody who is very symptomatic, mMRC scale more than 2, but does not have lot of exacerbation. We call it B. And then D is somebody who is both very symptomatic and lot of exacerbation. So remember, we have characteristics or classification based on the FEV1 or the lung function, and characteristics based on the symptoms and the exacerbation. What are the additional studies that you need to do for anyone with COPD? You need to screen for alpha-1 antitrypsin deficiency, because if the patient has that, you can give him the enzyme infusion. Also, you need to screen with chest X-ray or chest CT scan to look at what kind of emphysema, as I illustrated before. You can do lung volume and diffusing capacity, which is lung function test other than spirometry, more detailed. You can do pulse ox or blood gas measurement to see if he's CO2 retainer or not. You can do exercise testing. You can also look at Bode score. I'll talk about it in the next slide. And you can measure some biomarkers such as CRP and others. This is the Bode score. Bode score is important to know because any patient who have advanced Bode score, he has advanced mortality. So it stands for body mass index. So if the patient is thin from the COPD, he has increased mortality. O is the degree of airflow obstruction. So you can see here, you can give points 0, 1, 2, 3 points, depends on the patient, these factors. And D is dyspnea, and E is exercise capacity index, or the 6-minute walk test. And as you can see here, Bode is from 0 to 10, and any factor above 5 is usually severe. Any score above 5 is usually severe, and any score above 7, you need to refer the patient for lung transplantation. Comorbidities in COPD are actually common, and these are the comorbidities that you can see in COPD. You can see heart failure, up to 20 to 70% of patients with COPD. Coronary artery disease, there's increased risk of MI, especially during COPD exacerbation. Peripheral vascular disease, osteoporosis is very common, metabolic syndrome, gastroesophageal reflux disease, and obstructive sleep apnea. So make sure you screen your patients for all of these comorbidities and treat them accordingly. You can see here the osteoporosis and COPD. The more severe the COPD here, the more risk of osteoporosis. So remember that this is from prednisone treatment and from smoking and vitamin D deficiency and other factors. So always screen for osteoporosis. This is the heart disease in COPD patient. You can have coronary heart syndrome, you can have angina, you can have MI, stroke, CHF, and you can have pulmonary hypertension or atrial fibrillation. Make sure you screen and treat for all of these diseases. What are the factors that are associated with increased risk for COPD exacerbation? Advanced age, severity of airflow limitation. The more severe the COPD, the more you are at risk of COPD exacerbation. If somebody has a lot of cough, mucus, and somebody has COPD for a long time, pulmonary hypertension, also blood eosinophil level, other comorbid conditions, GERD. If you have antibiotic use in the last month, your history of your risk of exacerbation increase in the next month, and also COPD hospitalization in the previous year and history of prior exacerbation. So if you had exacerbation before, your risk of exacerbation also increase. Now, as I said, the most important thing here in this slide is that any patient who have a lot of exacerbation, think about that. Any COPD patient who have a lot of exacerbation, his survival decreased significantly. So this is a patient with no exacerbation. His survival at 60 months is much higher than patient who have more than 3 exacerbations. So your goal here is to try to decrease the risk of COPD exacerbation in any COPD patient that you see in the clinic. You want to try to treat him with oxygen or bronchodilators or whatever, so that he does not go into COPD exacerbation. These are the causes of COPD exacerbation. 21% non-infectious. We don't know the cause, usually allergies or any other exposure, dust, fumes, etc. Bacteria, 30%, viruses, 25%, and 25% both bacteria and viruses. So what are the goals of your COPD management? Your goal is to relieve his shortness of breath, the patient, improve exercise tolerance, improve his health status, prevent the disease progression, prevent exacerbation, as we said, because each exacerbation increases the risk of mortality, and to reduce mortality. These are your goals of treatment. So what's the most important treatment for COPD? It's very simple. Quit smoking. Quit smoking. I show this slide to my patients, and I told them, if you're going to continue to smoke, your lung, you will lose 30 ml per year of lung every year if you quit smoking now. If you didn't quit smoking, you will lose double that. The rate of decline will be 66 ml per year. And if both of these patients start at a FEV1 of 80%, those who quit will end up at around 70% at 11 years. But if those who didn't quit will end up at 60%. So I tell them in 5 to 10 years, if you don't quit smoking, you will be on oxygen. If you quit smoking, you will live a normal life for the rest of your life. So that's the most important thing you need to tell your patients. The second most important thing to treat stable COPD and prevent exacerbation is vaccination. And what vaccine to give to COPD patient? Both influenza vaccine every year and pneumococcus vaccine. And we have two types of pneumococcal vaccine. Whatever you have available in your clinic, please give the patient the vaccine. What other treatment is bronchodilators? And what do you start treating COPD patients with bronchodilators? Depend on the stage of the COPD patient. If he's in GOLD stage 1, you can start with only short-acting beta agonist, like Ventolin or albuterol or whatever. If the patient is stage 2 or 3, you need more than that. You need either long-acting beta agonist, we call it LABA, or you need long-acting muscarinic agonist, we call it LAMA, or a combination of both LABA and LAMA. And look here, inhaled steroid does not have any role yet. Does not have any role yet. So, and that changed over the years. We used to treat with any COPD patient with inhaled LABA, long-acting beta agonist, and inhaled steroid. For example, Symbicort, which has both inhaled, like budesonide, which is an inhaled steroid, and long-acting beta agonist. We have now new inhalers that came that has combination of LABA and LAMA without steroids, and we prefer those because we know that inhaled steroids can lead to pneumonia in COPD patient. We try to avoid it. But when do we use inhaled steroid? We use it if the symptoms are still non-controlled, or for those patients who have a lot of exacerbation, then you can add inhaled steroid to the LABA and LAMA. And the inhaled steroid with the LABA and LAMA will decrease the exacerbation. So remember that. Other treatment include pulmonary rehabilitation, oxygen therapy, very important, and non-invasive positive pressure ventilation or BiPAP. When do you use long-term oxygen therapy? Use long-term oxygen therapy for any patient who have resting hypoxemia, which means that he comes to your clinic, you do a blood gas, and the PaO2 is less than 55, or you measure his oxygen saturation. His oxygen saturation is less than 89% on room air. Then you need to start the patient on oxygen therapy. Starting this oxygen therapy will help survival. And if the patient have evidence of CO2 retention or the CO2 is above 52, then you need to add a non-invasive ventilator, which is the BiPAP machine. So not only oxygen, you need to use oxygen and BiPAP if he's hypoxic and hypercapnic. So think about that. Other treatments include surgical lung volume reduction. This is mainly for patients who have bullae and they have upper lobe emphysema. Then you refer them to the surgeon to take that out. Lung transplantation, as I said, it has some factors on it. Not every patient qualify. And then bronchoscopic lung volume reduction, it's new modality. We put valves through the bronchoscope to do a lung volume reduction in the upper lobes for those patients who have upper lobe predominant emphysema. Other factors include smoking cessation, as I mentioned, lung volume I talk about, long-term oxygen therapy I talk about, NPPV, non-invasive ventilation, positive pressure ventilation I talked about, and pulmonary rehab I talk about. Pulmonary rehab is like exercise, graded exercise therapy for patients who have advanced COPD. It improves their health quality and their symptoms as well. So the pharmacological treatment, as I mentioned, depends on the grade 1, 2, 3, 4 for the FEV1, as I mentioned before, and also depend on the group. Remember group A, B, C, D, as I talked about. Group A, you need to use only the short-acting bronchodilator. Group B, which are the people who have not much exacerbation, but they are very symptomatic. You give them combination of LABA or individual LABA or LAMA, one or the other. Group C, which are the patients who have a lot of exacerbation, but they are not very symptomatic, you give them LAMA. LAMA was found to reduce exacerbation. But also you can add steroid here, or you can add LABA and steroid. And group D, which are those who are symptomatic and a lot of exacerbation, you can do LAMA, LABA, or ICS, inhaled steroid and LABA. Now switching gear to asthma, and I want to look at my time here. I think I still have around 12 minutes to talk about asthma, so there's still some time. So asthma is different than COPD, is that mainly there is reversible bronchodilation response, which means that you can reverse the process of the disease if you treated it early on, not like COPD. COPD is usually irreversible. So what is the pathophysiology of asthma? Usually airway hyperresponsiveness, airway remodeling, which means smooth muscle hyperresponsiveness, smooth muscle constriction, they increase in size and volume, and smooth muscle hypertrophy. And also you have a lot of mucus secretions as well from all the inflammation that happen in the airway. These are the cells. And remember, asthma nowadays is not a single disease. It's a cluster of diseases. You have two types of asthma nowadays that we deal with. Type 2 asthma, we call it, or type 2 inflammatory asthma. And under this is atopic asthma, which occurs in childhood, and eosinophilic asthma, which is also a type 2 asthma, occurs later in life. And you have non-type 2, which is usually, the type 2 is usually the inflammation is usually eosinophilic or atopic, IgE mediated. This is in type 2. We call it type 2 because it is type 2 T helper cells, Th2. T helper 2 cells are the ones that are responsible for this type of asthma. And the non-type 2 is usually neutrophilic. It's not Th2 induced asthma. So these are the airway inflammation in asthma. So again, as I said, we have two types. We have T2 high or Th2 high, which is T helper 2 cells high asthma, and Th2 low, T helper 2 cells low asthma. And the Th2 high asthma, usually allergic atopic asthma, which occurs in childhood. We used to call it extrinsic asthma in the past, which is the atopic asthma. It also includes the eosinophilic asthma, which occurs later in life, but still it's type 2. It's not IgE mediated, but it's type 2. And both of these conditions are steroid responsive because both of them are more allergic. And you have the non-allergic, non-atopic, non-eosinophilic, non-allergic T2 low asthma, which is mostly neutrophilic. It's poorly steroid responsive. So these are the two types of asthma that we know. Both this type has two types. So if you want to say 3, 1, 2, 3. Allergic atopic asthma, one of them. Eosinophilic asthma, second one, which is T2 high. And then you have the non-atopic asthma, which is T2 low, is the third kind. So remember 3 classes or clusters of asthma. What are the cytokines in type 2 asthma, which is the allergic asthma? You have interleukin 4 interleukin-5, interleukin-13. And by the way, we have medications for every one of them. I don't know if they are present in Palestine or the West Bank, but these medications, they are now widely used here in the States. The cost is an issue, but they help a lot to decrease asthma exacerbation. Interleukin-5, differentiation and maturation of eosinophils. Interleukin-13, recruitment of eosinophils into the airway and mucus hypersecretion. And interleukin-4 is IgE production by B cells. And we have blockers to all of those. We have also the IgE itself. There is a blocker to it. But the IgE, what it does, it activates mast cells and basophils to produce leukotrienes that recruit and activate the eosinophils. Okay, so remember these cytokines. So let's talk a little bit about the non-type 2 asthma, which is the non-allergic asthma. Usually the cytokines or the cells that predominate in this asthma is Th1 and Th17. Th1 and Th17, and both of those will lead to neutrophil inflammation in the airway. Remember, the allergic asthma, you don't have neutrophils. You usually have eosinophils or IgE, which leads to eosinophil maturation. And so usually it's eosinophils. But this one is non-eosinophilic asthma. It's usually neutrophilic asthma. We call it neutrophil inflammation. And usually the neutrophils lead to cytokine production and lead to these inflammatory enzymes that lead to increase in the smooth muscle mass and fibrosis and airway remodeling. So neutrophil recruitment includes airway mass, airway remodeling, and mucus gland. So this is the type 2 asthma and the non-type 2 asthma. The type 2 asthma, you have the allergic asthma or the asthma that occurs early in life. And it's usually, we call it childhood asthma. And you have the exercise-induced asthma as well, is usually type 2 or T2 type. And late onset eosinophilic asthma, this is a new entity. It occurs, eosinophilic, we call it asthma, occurs mostly in women at later stage in life, like, 40s, 30s, 40s. And it's also type 2, and usually it's treated with biologics. Aspirin exacerbated respiratory disease, or that's the triad of aspirin sensitivity, nasal polyps, and asthma. And you have the non-type 2 asthma that occurs usually in the adults. Usually it is associated with smoking and usually occurs in obese females. And it's usually neutrophil predominant. Okay, so remember these two types of asthma. And under each type, you have different classes. 1, 2, 3, 4, or this is, So that's how we classify asthma nowadays. It's not a single disease. So late onset eosinophilic asthma, which is the type 2 asthma, one of them, it's usually adult onset, not very late adult, like, around age 40s, 50s, mostly females more than males, few or no allergies. Usually the allergies, it's eosinophils, but you cannot identify the allergies. What's the marker for this is that if you do a complete blood test, you see elevated eosinophils in this kind of asthma. Usually you have sinus disease as well. Chronic rhinosinusitis with polyposis may have aspirin sensitivity. They have frequent exacerbation, low lung function, but usually they are steroid responsive, and usually they respond to the anti-IL-5 biologics. Aspirin exacerbated airway disease, or we used to call it, aspirin sensitivity asthma. Usually it's the triad, Samter triad of asthma, chronic rhinosinusitis, and nasal polyposis. And prevalence is 7% of adults with asthma. And you treat this with, it's non-IgE mediated. You treat this with the same way that you treat asthma, but you need to make sure that the patient is not exposed to non-steroidal anti-inflammatory drugs. Although if you do desensitization against the NSAIDs, that will help the patient actually, and they can be on NSAIDs or aspirin after that. That's how we classify asthma severity. You all know this slide very well from your medical school. So it's intermittent, mild, moderate, or severe, and depend on the symptoms, the nighttime awakeness, how much time they use the short-acting beta agonist or the albuterol, and then the lung function and the interference in their life. And you can look at this slide and know the severity of asthma. And that's how we treat asthma nowadays. It changed a little bit. This is the 2020 GINA guideline, the Global Initiative for Asthma, in that we used to start treating the patient with short-acting beta agonist as needed, or albuterol or Ventolin as needed, but now they're telling you, you actually need to start steroids early, because if you start steroids early, you can control the symptoms better. And as you move from step 1 to step 2, 3, 4, then you can add long-acting beta agonist to inhaled steroid, or you can add a low-dose oral steroid therapy. And if the patient still has severe asthma, then you need to probably start him on biologic, which is anti-IL-5, anti-IL-13, or anti-IL-4. Inhaled steroids for persistent asthma, they reduce mortality, as I said, and that's why you need to start them very early. Inhaled steroid plus long-acting beta agonist, or LABA, both of them, they improve the lung function and decrease risk of asthma exacerbation. So if the patient symptoms are not controlled with inhaled steroid alone, you need to add LABA to it, long-acting beta agonist. Long-acting muscarinic agonist, you can add it in addition to ICS and LABA if the patient's symptoms are still not controlled. Leukotriene antagonist, like Singulair, you can use it only in patients who have mild asthma and their symptoms are not controlled. So I will, 3 minutes left, I think I'll talk about severe asthma. Severe asthma is the asthma that is not controlled with oral steroid treatment, and also it has a lot of exacerbation over the last year. You need to look at what factors can affect patients who have severe asthma. First, you need to make sure that they're doing their inhalers correctly. So make sure you demonstrate how to use their inhalers with them, so that will help a lot to decrease the risk of severe asthma. Then you need to treat some comorbid conditions. For example, GERD, you need to treat GERD in these severe asthmatics, because treating GERD will help their peak flow, lung function, quality of life, and will reduce their exacerbation, and it's very prevalent. Same thing, you need to treat their sinus disease. You need to add nasal steroid and nasal saline irrigation. Both of those will help with their chronic sinusitis disease. And if the patient is obese, the risk of asthma is higher, and therefore they need to lose weight. And losing weight, whether surgical or dietary, is effective in controlling the asthma. And if they have anxiety or depression, you need to treat that as well. These are the biologics for asthma. Omalizumab, it's anti-IgE, and we use it for patients who have elevated IgE level or atopic asthma. Mepolizumab or Nucala, it's anti-IL-5. We use it for eosinophilic asthma. Rislizumab, same thing, eosinophilic asthma. Benralizumab, Fasenra, we use it for its anti-IL-5 receptor. We use it for eosinophilic asthma. Eosinophilic asthma means you have to have eosinophils in the blood more than 300. So if the white blood cell count is 4,000, 300 of those need to be eosinophils. And type 2 low asthma, as I said, the non-allergic, the neutrophil predominant asthma is very hard to treat, but sometimes we use macrolide to treat this, or sometimes we refer them to bronchial thermoplasty. Occupational asthma, remember, some patients who have adult onset asthma. Remember, if a patient develops asthma at age 40s, 30s, and he doesn't have asthma as a kid, think about either neutrophilic asthma or occupational asthma, which means that the patient starts on an occupation, and that occupation is leading to his worsening asthma symptom, and you need to take him away from that workplace. And a lot of workplaces can lead to asthma. And these are my references, mainly the Global Initiative for COPD, the Global Initiative for Asthma, and the American College of Chest Physicians. Thank you very much, everyone, and hopefully I will take all your questions whenever